My name is Dennis Yan, the Director of Third Space Endoscopy at the Center for Interventional Endoscopy here at Advent Health, Orlando, Florida. On behalf of all my co-authors, I would like to introduce our study titled Prospective Analysis of an Endoscopic Impedance Planimetry Pyloric Measurements and its Association with Clinical Outcomes in Patients After Gastric Endoscopic Myotomy. Gastroparesis is a prevalent chronic debilitating condition characterized by symptomatic delayed gastric emptying without mechanical obstruction. Recently, GPOM has emerged as a potential pyloric-directed therapy for patients with medically refractory symptoms. The aim of our study was to use a real-time functional luminal imaging probe, or FLIP, to evaluate the association between pyloric physiological measurements and clinical outcomes after POEM. So our study was a single-center prospective study of all patients who underwent GPOEM for refractory gastroparesis between January 2022 and March 2024. As part of our protocol, endoflip was performed immediately before and after the GPOEM, and then at the time of follow-up endoscopy. The primary outcome was to evaluate the relationship between pyloric measurements and clinical response to GPOEM. A total of 148 patients underwent GPOEM during the study period, of which 58 were excluded. Among the 90 patients included for analysis, 64 patients, or 71%, responded to GPOEM based on an improvement of at least 1 point in the overall gastroparesis cardinal symptom index, or GCSI score, at a median follow-up of 6 months. This table summarizes some of the main characteristics between the two groups at baseline. Overall, there were no differences in patient demographics, etiology of gastroparesis, median duration of symptoms, or pyloric Botox injections prior to the GPOEM. When compared to non-responders, patients who did respond to GPOEM had less gastric retention at 4 hours, yet a higher baseline GCSI score. This slide summarizes the results of the FLIP measurements. Overall, there was a significant improvement in pyloric distensibility index following GPOEM among all patients. However, as shown in the bar graph, on follow-up FLIP at a median of 6 months after a procedure, the distensibility index remained significantly higher than baseline only among clinical responders, but this had trended towards baseline among non-responders. We performed a receiver operating characteristic curve analysis to estimate the association between pyloric distensibility as measured by the FLIP and clinical response to GPOEM. A distensibility index threshold of 7.35 or less was associated with a clinical response to GPOEM with a specificity of 80.8%, sensitivity of 60.6%, and a positive and negative predictive value of 88 and 46.7% respectively. In all, GPOEM continues to garner attention as a potential therapeutic intervention for patients with medically refractory gastroparesis. Nonetheless, the reported clinical response to GPOEM remains quite variable, with success rates ranging anywhere between 45 to 75%. Hence, it is really imperative to identify potential predictors of response in order to optimally select patients who may benefit from this procedure. This prospective study suggests that a low baseline pyloric distensibility index may be associated with a clinical response to GPOEM. Furthermore, patients who respond to the procedure endorse a sustained increase in pyloric distensibility index at 6 months when compared to non-responders. We should emphasize that the role of FLIP in the evaluation of GPOEM remains to be determined. Specific standards for FLIP measurements are still evolving, and additional data is needed to establish cutoff reference values. Future comparative prospective trials with larger sample sizes and standardized split protocols are needed to corroborate our initial findings. Once again, thank you for tuning in, and I invite all of you to read the entirety of our study in endoscopy. Thank you.